Vic Warparian. I am a cardiac electrophysiologist by training. That means that my training is in cardiology, and then I've spent a couple of 3 more extra years training in treating arrhythmias, rhythms of the heart when they're too slow or too fast. And we're going to talk about pacemakers, and I'll talk also about defibrillators, which are 2 separate devices. And I was just saying as I walked in this very hurried fashion that I'm going to spend about 15 minutes talking about I'll talk for about 15 minutes. Is that about good? 15, 20 minutes?
Sure.
And then we will add about a 10, 15 minute electronic presentation as well. It will kind of consolidate or reinforce what I presented on the board, just in case I leave gaps there. The purpose of it is for you to have a good understanding of what these devices do. Yeah, and if you don't need one, you don't want one. I mean, that's for sure. Okay, so I do want to ask a quick question. Who's the audience? Some of the audience have devices. Others have family members who have devices. So I take it everybody is a patient. Is anybody else from the organization here from Pro Healthcare?
No, for the most part, we're cardiac patients.
Okay, excellent. So you can write questions and please ask me, and I think I'll be able to answer them. Okay. So let's talk about the heart. Okay, this is about the heart because these devices relate to the heart, and I'm going to draw a diagram. I'm going to draw a schematic of the heart, and so. And I will stand out of the way because I'm not transparent. Okay, so this is a kind of like a schematic of the heart. And this is the heart, the lower chambers of the heart. And these are the top chambers. These are some of the vessels that come in on the right side. And then it's the function of the heart is to pump blood. Let's look at the time here. Okay. So the function of the heart is to mechanically circulate the blood in the body. So that means that's where the muscle that comes in, it squeezes and circulates the blood. And there are large vessels that obviously bring in the blood to the right side of the heart, which then goes to the lungs. And then from the lungs it comes back, gets oxygenated, and comes back to the left side of the heart through the upper chamber here. So there's upper chambers and lower chambers. Now anytime there's a muscle that needs to contract, it requires a stimulus. So when I'm moving my hands and talking, for example, it's my brain in this case sending electrical signals to my muscles and such. That's why I'm moving around here and talking. The heart has its own electrical system. It doesn't require the brain to tell it, activate. So the heart has a bunch of cells here, normally, that get activated and send electrical current throughout the top chambers. I'll use red, right? Yeah, it's really nice. And then so it sends these through, and then there's an area there that kind of processes the signals, but just there's a highway that takes it down to the bottom chambers. So if you look at this, if you look at an EKG, which would be a normal EKG, kind of looks like this. Like if you thought about the electricity traveling through the heart, this would be one, let's say time-wise, this would be the first event in the 2 top chambers, and then the bottom chambers would be 2. Now, I just want to add, and if I'm talking, if I'm explaining too much, it's okay, you can throw the rest out, just remember it, whatever. So everything is insulated between the top and the bottom chambers of the heart. So if you look at this plane here that I'm drawing, it is insulated, except for this highway. So that's important. Why is that important? Because if something happened to this highway and it slowed it down, then you can figure out that the electrical impulse will not, the signal will not get down to the bottom chambers. And why is it important to have a signal? Because the signal, electrical impulse, is needed for the muscle to contract. Without that, there's no muscle contraction. The muscle just stays. Perfectly healthy muscle, just like my hand, my biceps would be perfectly healthy. If I had a stroke on one side that controlled the arm, my muscle is perfectly healthy, but it won't contract unless a signal goes to it. Similarly, the heart can be perfectly healthy. If an electrical signal doesn't go there, it's not going to contract. Okay? So now we'll talk about what can go wrong with this electrical system. So if this is 1, this is 2, 1, 2, 1, 2. The big squiggles are the bottom chambers electrically getting activated, and the tiny squiggles are the top chambers. So now if you have certain things can go wrong in the body, it's not always related to age. So one thing that can go wrong would be, for example, if something occurred and chewed up this highway. What can chew it up? Well, I could get a condition where a certain tissue can infiltrate that conduction. It's not common, but that conduction wire. And then so what you will have is you'll have a bunch of ones, and then maybe you'll have one conducting. And so you'll have a slow heartbeat, and the reason for that is because of the fact that the electricity is not traveling through the highway, because the highway is damaged. That's one condition. Now you can have another situation where the highway is conducting fine, thank you. So you have this fine, but where the electrical impulse is coming from is going very slow. So instead of doing like the normal heartbeat is about 60 times, or maybe it varies from 40 to 60 times per minute. Now we have all sorts of modern devices that actually records your heartbeat. They sell the Fitbit and such. Some of them do. So the point there is that the normal heartbeat, if you were to nourish the heart and suspend it in a preparation, it can beat by itself at about 50 to 60 beats per minute. Now it is under the influence of the brain, but the brain doesn't consciously tell it to contract. If somebody got scared of something or you're running away, adrenaline can affect these cells. It can make them fire faster, so they will go faster. If you're sleeping at night and resting, there's other neural impulses that will slow things down. So it will just kind of like slow it down. It will go like that. It just kind of, person is sleeping, heart rate goes down to 40. Very normal, perfectly nice. But what happens if somebody in daytime, they're running around, and this area is sluggish? I think I've scratched enough here. Do you guys think I've scratched enough on this one? Okay, very good. All right, so what we'll do is
Rip it off.
just rip it off. Thank you. Okay, very nice. These are artwork. We'll sell them later. Very precious. I'll sign them or something. Okay, so what if somebody's heart rate? So we said this is the normal heartbeat, right? I mean, we said that this could be normal. I mean, normal is something. There's all of us are old here, and there's no such thing as a normal. Is a huge variation. There's no such thing as normal, right? I mean, there is, but so if you look at what if somebody's heartbeat was like kind of like taking pauses. Now this is not a conduction block. Notice this is not a conduction block, but that area where the electricity was coming from, which was like we said up here. As you can tell, I've grown the heart a lot. So the impulse was coming from out here. Okay, what if that area is slowed down? Okay, so if it slows down, then you're going to have a slow heartbeat. So I could be standing here, instead of my heart rate going at about 80, then it will just be like at 30. Okay, and just because this area is not firing at automatic by itself, it's either diseased or there's fibrous tissue growing into it. Sometimes with age it happens. Sometimes even at a younger age it can happen. Sometimes it can happen in somebody in their late 50s. So that's another condition where the heart rate is so slow, or the impulse generation is so slow that the heart is not contracting, and the function of the heart being to circulate the blood in the body, you don't have enough circulation, and so therefore you would be tired. You want to go up a flight of stairs and your heart rate is not picking up. So you feel tired. You just feel, oh gosh, I'm tired. I can't go on. Now you can be tired from many other things as well, but if somebody were to monitor that person, they will see that their heart rate is fixed at 30. So just a quick recap, one problem would be the heart is not firing fast enough. The other possibility is that the heart is firing just fine, but it's not, the electricity is not going down to the bottom chambers of the heart. Okay? So that's called heart conduction block, not blood vessel block. That's here. That's kind of here. That would be right here. That would be conduction block. And this other one is if somebody had a big, huge heart attack, for example. Okay, it can chew up the wires. That it can snip the wires. That's not good. And then you will have this kind of a situation. Okay. So the other problem, so this is one of them, the conduction block. The other one is where the impulse is originating, it's slowing down. Okay, so what do you do? What you do is, so humans figured out that this is what can go wrong with them. And pacemakers essentially treat slow heartbeats. So these are examples of slow heartbeats. This is an example of slow heartbeat, because there's nothing that's going down to the bottom chambers at times. This is an example of a slow heartbeat because the impulse is not firing frequently enough. So the pacemaker's job is to keep time. So the pacemaker has to see what's happening, and after seeing what's happening, it will then start a timing cycle and say that, oh, wait a minute, I am programmed at 60 beats per minute, and I just sensed this person have a heartbeat at a certain time, at a specific event. Like, so let's say the person had something like this, the pacemaker will sense that, and then it will start a timing cycle and say, okay, it's 1 second, which is 60 beats per minute. I expect to see a heartbeat. It sees one, it shushes up. It sees one, it shushes up. And then here it doesn't see one, it will put a pacemaker spike and it will pace. Yeah. So then the pacemaker's job is to restore the electrical activity of the heart. So if there's conduction block, it does something else. It will sense the rhythm in the top chamber, and I'll tell you how it does that. But just let's go along with the fact that it can do it. And then it will go ahead and put another pacer spike in the bottom chamber of the heart. So if you had a situation like, where the electricity was not conducting down, and sometimes it was conducting, it's able to sense that in the top chamber and then put a pacemaker spike and then pace the bottom chambers. How does it do that? What's a pacemaker spike? I just brought in a new word, okay? Pacemaker spike. A pacemaker spike is an electrical impulse, just like the native electrical impulse of the body, that captures the heart. So it sends in electricity, and then the muscle around that area gets activated as if it were getting activated from top to bottom, but it's getting activated in a different way, and it will then contract, which is what we want it to do at that specific time. Okay, so that's how it works. So now if it's like this, where the top chamber is going very slowly, okay, it will start a timing cycle and then say, okay, this is 60. Where's the heartbeat? There's no heartbeat. Okay, I'm going to put a pacemaker spike. And then it will put a pacemaker spike in the top chambers. It will capture it because I just drew this little signal there implying that it captured it. And then it will wait a little bit and says, oh, nothing is happening. It's not even going down to the bottom chamber. It puts another spike and paces the lower chamber. Now, the next heartbeat comes on time. It will say, okay, this, I sensed it. My timing cycle is fulfilled, I will just start it again. Okay, so it will just basically regulate the heartbeat in such a way that it's at the programmed rate of the pacemaker. Now do you guys know a metronome? Anybody here music? Yeah. So that's how the first pacemaker actually in Medtronics, Earl Bakken, he looked at the design of a metronome. And that's how he designed the pacemaker, electronics of it. He was an electrical engineer, and he saw the workings of it in not Radio Shack, in some kind of Popular Mechanics or something. True, and then he went ahead and said, okay, this is I'm going to design something like this. He was working in Minnesota, and University of Minnesota Hospital, and saw that these patients were having very slow heartbeats and knew that you could stimulate the heart by electrical stimulation, and that's how, and we will show a slide on that, and we actually will. So the first pacemakers were pretty big, they were huge, but their function was to pace the heart, because if you didn't give that to this individual, man or woman, they would pass out. Okay. Now, just a slightly different. Are you guys all with me yet, or am I? Right, very cool. Right. So now pacemakers are not defibrillators. Pacemakers are devices that treat slow heartbeats. Defibrillators are something different. The heart can do other weird. The heart can do other things. The heart can, if it's damaged, or if it has scar tissue, which requires me to tear this page down. Okay. There you go. These are actually sticking to those. Yeah. Yeah, it's pretty cool. Yeah, we'll just do that. A whole wall.
Wallpaper.
Yeah, it'll be good. So then I'm going to draw the heart again one more time because I just like doing that. Can't help it. Okay. So this is the heart, and we said it's an electrical organ. We talked about the conduction system, wires going down and activating the heart. But you can look at the heart muscle, right? The heart muscle is, first of all, for the muscle to be electrically activated, like you stimulate it at one point, and the whole muscle gets activated. Isn't that cool? Because the electricity is traveling through the whole heart, okay? So these are the valves here, insulated, except for that highway that we talked about. So what happens if somebody gets, now, if somebody's plumbing gets affected, okay? The blood vessels, not the electricity, the plumbing, okay? So let's say I am at 58 or 59 and I get like a crushing chest pain because I have plaque in my coronary vessel, and then it totally closes down, and this is not in the electrical system, it's in a blood vessel that supplies the heart muscle. Now let's say that it gets blocked because the plaque ruptures, and on top of that, the vessel closes down. Now, it's not good. I'll get chest pains, I'll be sweating, I won't be able to talk to you. So you will miss all this talk. But what then happens is that, what then happens though is that the area that it supplies will get chewed up. So this is kind of like a, remember that this is a heart muscle, and that's important because its job is to contract and to push blood. Now, if a segment of it is chewed up, well, one thing that happens is that it's not going to contract as strongly, although it will adjust. It will adjust with the right method. But then the other thing that can happen is that electrically, that's a scar. That's a blind area. Okay. So if you were to take the heart muscle and let's say you open it up like as a fabric, okay, and normally, like it has fibers, okay, and the electricity is going to travel like that, okay, in it, okay, because it's kind of going to go along the fibers. Actually, it should go along the fibers. Now, what happens if you take a chunk out of this? Like you're not actually punching a hole in the heart, although that can happen. But what you're doing is you are electrically killing that area off, okay? So then so it's not going to be able to travel through that area. We're not talking about slow heartbeats now because the electricity has already gone down to the bottom chambers, okay? But then what it can do is it can start turning around that scar. Just like if you put a rock in a river or a brook or something, the water will start going around it. Now, in certain cases, that electricity can turn around and around and around and around, and that's not good because if it does that, then it will start driving the heart, not too slow now, it will start driving it at the astronomically fast rates, like very fast rates. So you have the normal heartbeat coming along. I just kind of had to compress it because I'm on the side of the paper. Now then something like that happens and the heart starts, it's uncool. It's not a cool thing because if it does that, then its contracting ability gets affected. It's going so fast, it doesn't have any filling time. It can't fill up, it can't act as a pump. And it's just as bad as having a slow heartbeat, except it's worse. It's worse because of the fact that if this doesn't stop, then that's like the heart is not able to contract. And so then the blood doesn't get into the rest of the vessels. And what then happens is that it can then, basically it's cardiac arrest. That's what we understand as ventricular fibrillation or ventricular tachycardia arrest. So somebody came along, well then they figured out that they can stop this after it happens. Ideally you want to stop it before it happens. But they figured out that if they shock the heart, it will reset it and it will go back into normal heartbeat. I will not draw on the paper here. So, on the wall. So, because they won't let me give this talk again ever. So, all right, so that's what happens when you see like the EMS, but the defibrillator part, what does the defibrillator do? The defibrillator senses the fast heartbeats. Defibrillator is like a lead, nowadays it's a lead system. The original defibrillators had a sensing component, which was, let's say, some leads on the heart. Let's just say minus and plus. It would go into this device. I'm just going to draw a crude device. Okay? And then and it would monitor this. Once it sees this, it had two other leads that were patches around the heart. Actually, a surgeon would do an open heart surgery and put two pads, they look like fly swatters actually, on the heart, just like the external defibrillators. And these would go to the treatment circuit. And it would then, once it senses this, it would then deliver a shock between these two pads and cardiovert the heart. That's an implantable defibrillator. So that's a defibrillator different than a pacemaker because it treats fast heartbeats, not slow heartbeats. And fast heartbeats can happen because of a previous heart attack. That's the most common. But it can also happen because the heart is perfectly healthy, but some people are born with an electrical anomaly in the ion channel. We don't want to get too much into that, but there's inherent instability of the electrical activity of the heart, implying in English that, I don't have a slight accent, but you understand me all right. Okay, so, but what that means really is that the electrical instability of the heart is based on the fact that it's not able to conduct electricity within it's missing some ion channels from birth, or they're modified, or somebody takes a drug that changes that. And so out of the blue, the person's rhythm is, for example, like normal like that, and then they throw a skip beat, and then it will destabilize without any scar. It will destabilize the electrical activity. Those are called congenital inherited arrhythmic disorders. So there are different ways in which you can get into this fast heartbeat. And the bottom line, though, is that if you don't do anything about it, usually the person would likely die. So somebody had a heart attack in 1995. Actually, let's say 1998. And it's 2015, right? Yeah, 2015 now. 15 years later. The scar tissue took that long. The scar tissue was there, but the instability doesn't show up until later. So then they're kind of having a meal and they drop dead. Did they have a heart attack? Did they close a vessel? Or did something like this happen? Likely something like this happened. Or they didn't close yet another vessel, but they had an electrical storm in the heart. That's where the defibrillator, so nowadays, if somebody has had a previous heart attack and their heart function is dropped to less than half of normal is about 60%, and we can just, again, we've been talking about 17 minutes now. So, yeah. So then, so you got time, everybody? That's so cool. I love it. I'll be in your shoes soon. Before I know it, it's good. So, so what happens then is that 10, 15 years later, the electrical properties around the scar tissue develop in such a way that you can have an unstable rhythm developing. So this person can get a cardiac arrest from an electrical storm 10, 15 years later. Now, the efficiency of the heart pump that I was talking about, so do you want to wait until everybody, how can you tell everybody who's had a heart attack? Because everybody who's had a heart attack gets a defibrillator, so people have struggled with this. People meaning like the medical community. And so then they talk about risk factors, and the risk factors are such that if somebody's ejection fraction is less than half, because they went ahead and did randomized trials. They said, well, it used to be when I did my training at first, I'm jumping a little bit from topic to topic, that you would, you would see somebody have something like this for a short burst when you were monitoring them, and you took them to the electrophysiology lab and tried to start it up there, and if you could, then you would say you're at risk. But now, for people who've had coronary disease and have had damage to the heart, if the efficiency of the heart pump drops below 30%, you know that these patients are at high risk. High risk meaning that over a period of about 5 years, 20% of them may drop dead without them ever showing you this. So that's why the guidelines say that if the cardiac function drops to half of what it should be in a person who's had a heart attack 3 or 4 months later, not just right away, but after things have healed up, then they should get a defibrillator as a preventative measure, even though the person has never had it, and never had an arrhythmia. So we talked about, so I want to summarize this. I may have lost you a little bit there, but that's okay. I don't think so, but that's all right. So we talked about pacemakers for a slow heartbeat. We talked about defibrillators. You probably are wondering, do defibrillators pace? Now, nowadays, defibrillators are not like this at all. They are not patches and leads. Now, nowadays, defibrillators, they have cleverly devised this defibrillator and in the form of a pacemaker. So there's one sitting there. That's a model of one. So I'm going to have to just kind of like go on my business of covering the walls here. Okay, good. All right. So defibrillators, I'm going to draw the heart again because I like doing that. All right. So a defibrillator, it doesn't have those patches that we drew, or the thing, but it's still a complete defibrillator. It has a pacing lead. It looks like a pacemaker lead, and we will pass one around. But it's not a pacemaker lead. It is a pacemaker lead, and it's not a pacemaker lead. It's not a pacemaker lead because it has something extra. It has a coil that is embedded in it, which acts as an electrical surface. It's a high-density coil, so it's a large surface area. And the device itself is a pad, so you can then shock between the coil and the device, and it's the same as having 2 pads on the heart. Now this one, you don't need to crack open a person's chest. You can put it through the veins, put it there. And it also has the sensing circuit because it has all the 2 electrodes that were screw-in electrodes, these guys here. Oh yes, all right, okay. We're going some places here. All right, good. So you had the sensing here and these electrodes that were, this is the treatment electrodes. Now your sensing is embedded in the tip of this lead, and there's the coil. Sometimes you have 2 coils. Does this have 2 coils? Yeah. So it will, then the shock will go, well basically you want to sandwich the heart. Anybody hungry here? You want to sandwich the heart between the coil and the 2 shocking components. So it senses, integrates, and it does all the pacing too. So the defibrillator will do, so all defibrillators are pacemakers. Okay? All right.
Now, do they put a pacemaker in plus the defibrillator, or is that just that?
Just defibrillator. If somebody needed a defibrillator, they will have all pacing in there. Now you can have single chamber defibrillators or dual chamber. If somebody really needed pacing, they will get a defibrillator that doesn't look any different than another defibrillator. So you don't get two components, you just get everything is contained in one. But the cost is very different. So you don't want to give a defibrillator to someone who just needs a pacemaker, not because you're trying to save money, because you don't need it. It's not, I mean, you don't want to run the risk of getting a shock as well when somebody does not need that at all. Okay. So now there's also one more thing. We talked about pacing, and then I think we'll just, and then I'm going to fumble with this thing here so we can show the slides, and then you will know everything. You guys can go implant defibrillators after that.
All right.
Very nice.
Medical school.
Yeah, that's it. Cool. And if you have any questions, let me know too. And it does explain. I mean, those pamphlets, they're not like this, but it does pretty much explain what what we're doing here. So so we talked about I'm not trying to be clever here, but I will take another one of these. It's very good. Just see.
Good.
Yeah, I know that. There's good. Yeah, it is very good glue. And it's really neat, actually. It works better than a presentation. So, I mean, than a PowerPoint, actually. Does the video get all this? It's very nice. Pretty funny.
You got you on tape, so watch it.
Yeah. Okie dokie. So what I was saying earlier was that I said that, okay, the electricity starts up top with the pacemaker, that is, the slow heartbeats, and then travels in the top chambers and then goes to the bottom chambers. And I said that if something goes wrong, and then think there's only one highway normally that does that, and then once it crosses that highway, it will, I just drew that highway there, it will bifurcate into two, it will network into the two lower chambers. Now, what if somebody had some condition where one of these branches was chewed up? I mean, we are not made of, we're vulnerable, right? I mean, we don't have, so we're made of stuff. And what if this cable got chewed up? Well, if this cable gets chewed up, the heart will still electrically get activated. But it will get activated in an abnormal way, or abnormal is not a good term. It will get activated in a different way than it normally does. Okay, so normally when the electricity goes from top to the bottom chambers of the heart, normally it will activate both lower chambers, and we did say electricity is needed for contraction, right?
Yes.
Just like, yeah. So then what happens is that both these will kind of like normally come in, like they will get activated. So the top one gets activated, and then the bottom one. So you will have people do this gesture when they're talking about the heart contracting. So then if you look at both chambers, they will be contracting like this. Now, if you chew up one of these branches on the left side, so it's called left bundle branch block. Now, so what? If somebody has left bundle branch block, so what? Well, then the contraction will be out of sync. So then you will have the right side contracting and then the left side. So then you will have this kind of like undulating type contraction where the right side contracts and then the left side. So it's just kind of like, even though the muscle can contract, it's just contracting in a very dysynchronous, what's referred to as dysynchronous or asynchronous way. And so in a situation like that, what you can do is nowadays, this is the third level yet of pacing, is that you can pass a lead to the left side. You cannot put it in the cavity. This is a minor technicality. But you can pass a lead to the left side and activate both lower chambers at the same time so that you can make up for this. Now, if somebody had an isolated problem an isolated problem of a conduction defect on the left side, without any other damage to the heart, it's okay, because yeah, it's not perfect contraction, but the rest of the heart can make up for it. But if somebody already has a reduced cardiac function and you do this, then you've got a problem, because now the heart function efficiency is 30% because not all the segments are, some of them are deadened. And on top of that, you're activating the heart in a weird way. You're activating the heart in a dysynchronous way. So you do that, then the heart function will, then the efficiency of the heart pump will drop further. So then by putting that lead on the left side, but you can correct it. That's a 3-lead system. Okay. Did I lose everybody? No? I think we're good. All right. Okay,
So
so
a quad actually has 3 leads.
Who?
A quad.
A quad has, yeah, it's called quad. Now, why is it called quad and it's got 3 leads? That's a good question. Why don't we do that? Why don't we answer that question? Well, okay, so that has something different. Now, it is true. It's a 3-lead system. Nowadays, a lot of devices have that. That has to do, the quad refers to the 3rd lead itself. It's not talking about the atrium. This is called atrium. It's called right ventricle. The quad refers to the left ventricular lead itself. And the lead, okay, I'm going to do a picture. I can't help it. All right, so the quad refers to the fact that there's a lead in the top chamber of the heart, and just draw it like that. There's a lead in the bottom chamber of the heart. And then the lead that goes on to the left side, when they first made these leads, they made them like with 2 electrodes. Now, they make their leads that have 4 electrodes on it. 4. It doesn't refer to that you have 4 leads in the heart. One lead has 4 electrical connections on it, and then